Good afternoon, class. Welcome back to Nursing 202. In this recording, we're going to be looking at Module G, Neuromuscular Alterations, and this will be the first in a series of recordings. Shown here are all the alterations associated with this module. In this recording, we're going to focus on headaches, ALS, multiple sclerosis, and myasthenia gravis. So let's begin by looking at headaches. The three types of headaches we're going to focus on are tension, cluster, and migraine. A tension headache is associated with muscle contraction and stress, and it typically lasts 30 minutes and can last up to 7 days. We see bilateral pressure and tightening with this type of headache. With a cluster headache, we see recurrent unilateral headache, and it's usually accompanied by ipsilateral autonomic symptoms, and there are triggers that usually are associated with cluster headaches. And migraine headaches are more severe and recurrent and long-lasting, and they may or may not be associated with aura. So let's look a little bit closer at the tension headache. The tension headache is common in adults and adolescents, and the causes are not fully understood, but it is associated with tension in the muscles of the face, neck, and scalp. It's estimated that 79% of people experience tension headaches in their lifetime, and risk factors include emotional stress, anxiety, depression, panic disorders, obsessive compulsive disorders, people that are having trouble sleeping, and certain medications may also be associated with it. Skipping meals and premenstrual syndrome are also associated with tension headaches. Again, it's a bilateral, generalized, usually located in the frontal occipital lobes, constant dull pressure or band-like headache associated with neck and shoulder pain. These patients may have a history of recurrent headaches, and a neurological workup is necessary. Sometimes we see cervical x-rays, spinal x-rays, sinus x-rays, EEGs, and CAT scans or MRIs are used to diagnose these, to rule out some other pathological causes. Treatment includes assessing the pain, administering analgesics such as acetaminophen, aspirin, or non-steroidal anti-inflammatory drugs. These type of headaches sometimes are difficult to differentiate from migraines without aura. We want to educate our patient to keep a headache diary and to look for triggers that may be causing the headaches, such as skipping meals, sleep problems, smoking or trying to quit smoking. We want to educate them on how to take their medications. Massaging the neck, jaw, shoulders, and scalp may be helpful. Taking a hot bath, lying down and placing a warm cloth on their forehead may be helpful. Biofeedback may be helpful as well. With cluster headaches, they're quite rare. They can be episodic or chronic, and the attacks can be triggered by factors such as hypoxia, alcohol, vasodilators, cigarette smoke, strong odors, and some of the other triggers similar to the tension headache. These are diagnosed with a history, a physical exam, and again some of the various x-rays. Treatment includes, again, assessing the pain. Administering oxygen is a treatment for this type. Administering abortive medications There are various medications that may be administered, and we're not going to get into the specifics on that. And prophylactic medications such as calcium channel blockers, such as verapamil, anticonvulsants, and lithium have been used to prevent these type of headaches. So the symptoms include unilateral headache and facial pain in clusters over a period of weeks, and usually accompanied by unilateral autonomic symptoms. The pain can be described as sharp, burning, penetrating, and starts suddenly without any warning, and actually ends abruptly as well. You want to educate your patients to keep a headache diary, to look for triggers, avoid known triggers, become familiar with possible adverse drug effects, emphasize the importance of seeking medical attention with worsening symptoms, especially sometimes with some of these headaches they do get suicidal because they just get so tired of dealing with the headache. So warning them of this and their family members is important. Now we're going to talk about migraines. Migraines are severe, recurrent, long-lasting headaches with or without aura. And when I say that, I'm talking about visual or sensory disturbances that typically occur 1 hour prior to the onset of the headache. We also see some prodromal symptoms, which are generalized symptoms that can precede a headache by up to 2 days with migraines. Migraines tend to be unilateral. They're described as a pulsating type of pain, and they're associated with nausea and vomiting, photophobia, and that's a fear of bright light due to hypersensitivity, and phonophobia, which is a fear of sounds due to hypersensitivity of sounds. They can be so severe that bed rest is necessary, and they can decrease the quality of life and decrease workplace productivity. They usually first appear in childhood and adolescence or early adulthood, and they can increase in intensity and last from 4 to 72 hours. And in some cases they can actually last longer than that. Risk factors: women are 3 times more at risk than men, and these headaches tend to run in families. 70% have a first-degree relative that has a history of migraines. Signs and symptoms again include nausea, vomiting, blurred vision, anorexia, increased sensitivity to light and sound, visual disturbances, restlessness, irritability, aphasia, fatigue, dizziness, numbness, tingling, all sorts of symptoms. And again, the aura signs and symptoms may include flashing lights, blind spots, and tunnel vision. The prodromal signs and symptoms may be changes in mental status, such as depression or hyperactivity, neurological manifestations, such as hypersomnia, photophobia, stiff neck. There are no lab tests to diagnose the migraine, but there are tests to evaluate underlying causes. These include serum chemistry, serum and urine drug screening. We see a central spinal fluid examination sometimes done to rule out or evaluate for infection or subarachnoid hemorrhages. We see CAT scans, MRIs, and EEGs also done. Someone that is having migraine, you want to monitor their vital signs and pain, provide symptomatic relief with analgesics, antiemetics, and sometimes tryptophan agents are also ordered. You want to administer prophylactic medications. A lot of times these folks are on beta blockers, tricyclic antidepressants, and anticonvulsants. Provide emotional support and educate them and their family. Assess their coping, anxiety levels, and their knowledge deficits, and provide them with education. Refer them to mental health clinicians if necessary. Red flags: if they become nauseous and vomiting and become so severe this can induce shock, so they are at risk for fluid and electrolyte imbalances. Overuse of medications with migraines can cause rebound headaches. Stroke is rare but is a possibility. You want to educate these folks to that this is a not curable condition, and educate them on their medications, and keeping a headache diary, exercising regularly, avoiding dehydration, getting plenty of sleep. Lying down in a dark white room with ice packs may be helpful. Try muscle relaxation exercises, meditation, yoga. Join a support group. So the cardinal signs and symptoms are unilateral pain, throbbing, photophobia, and phonophobia. And the aura may or may not precede the headache. You want to search for triggers. One thing that they've associated with people that do have the aura with the migraines, they recommend that they not be on birth control pills. If someone has aura migraine headaches, then if they take birth control pills, they're more at risk for stroke. So you want to caution them on taking birth control pills. The next condition I have listed here is ALS. ALS is a progressive neurodegenerative disease that affects the cells of the central nervous system, which eventually result in loss of almost all voluntary movement and death. It's also known as Lou Gehrig's disease for the baseball star who died of it. It's a devastating disease that typically strikes men between the ages of 40 and 60, more so men than women, and it causes death within 3 to 5 years. About 5% of people with ALS have a family history of the disease, but most cases are sporadic. ALS progresses to where we see loss of muscle strength, we see spasticity, muscle atrophy, flaccidity, and paralysis. Weakness commonly affects the muscles of the hands, the shoulders, the upper arms, legs, and those used for speaking, chewing, and swallowing. We see patients progress. We see them have dysphagia, which prevents adequate eating and drinking, which leads to weight loss and malnutrition and worsening of muscle atrophy, fatigue, and weakness. We see excessive saliva flow and emotional lability, not caused by a mood disorder, which can cause significant distress. Respirations are usually affected late in the course of ALS. We see paresis of the intercostal muscles and diaphragm, which compromise breathing, and dysphagia and lead to aspiration and pneumonia. Eye muscles are rarely affected. And the only other functions spared are sensation, intellectual ability, and bowel and bladder function. So it's a quite sad condition. The diagnosis is made on signs and symptoms of progressive dysfunction of the muscles. Signs and symptoms include muscle weakness, wasting, atrophy, often initially affecting the limbs and causing clumsiness, so dropping things. Muscle spasticity, hyperreflexia, we see that. We see dysarthria, dysphagia, and dyspnea, and fatigue. There's no diagnostic test to conclusively identify ALS, but what we see are signs and symptoms which affect nerve conduction studies. Muscle biopsy may also be used to help diagnose it. Neurological images such as an MRI and CT of the brain and spinal cord help rule out other disorders. So the course progresses from it progresses relentlessly without any type of remission or relapse or even a steadying of signs and symptoms. So it just hits and goes. After prolonged immobility, the patient typically dies of respiratory failure, aspiration, infection, or pulmonary embolism. With intubation and mechanical ventilation, they can live for years, but totally paralyzed except for their eyes. So these folks typically have to have palliative care from multidisciplinary professionals. Drug therapy can help manage the signs and symptoms, but don't arrest the underlying pathology. So when caring for somebody with ALS, we're concerned with preventing aspiration, maintaining adequate nutrition, providing support, fostering communication, and maintaining muscle strength. So we do that through a variety of strategies. We have to collaborate with pulmonologists and speech therapists. We have to monitor their respiratory status. Typically, we have to, eventually they wind up on a ventilator with a trach. So monitoring for the progressive problems with breathing, maintaining them on a ventilator. Maintaining a PEG tube is typically where we end up with these folks. They have to have a lot of support. It is a debilitating and fatal condition, and so a lot of emotional support is necessary with this condition. Our next condition we're going to talk about is multiple sclerosis. Multiple sclerosis is characterized by destruction of the myelin sheath, a lipid and protein-rich layer that acts as insulation for nerve fibers. And so you see the myelin sheath shown there. These surround the neurons, resulting in formation of plaque. So we get plaque buildup there on the myelin sheath. It's primary disease of the white matter tissue in the central nervous system. The white matter is made up of nerve fibers that are responsible for transmitting communication signals both within and between the central nervous system and the nerves supplying the rest of the body. So this myelin sheath is destructed or destroyed, and it's can be a chronic. It is a chronic, unpredictable disease with exacerbations and remissions. And this can occur over many, many decades. In many patients with MS, we see them permanently disabled and even death, although many live for many, many years like anyone else. The cause of MS is not known. However, there is some research that suggests that patients with a genetic vulnerability that this is triggered by environmental factors such as exposure to the Epstein-Barr virus. Clinically, it's difficult to describe MS because of its various unpredictabilities in nature of it. And it's dependent on the areas in the central nervous system that are affected and how badly they're affected, what symptoms we see. So it's unpredictable. It affects more than 400,000 people in the United States in early and middle adulthood, 20 to 40 years of age, and over 2 million people worldwide. It affects women twice as much as men, and it occurs more often in Caucasians of Northern European ancestry than other groups, although we see it in Black Americans, Asians, and Hispanics and Latinos. It's more prevalent in North America or in Europe in the colder climates. The progress and severity and specific manifestations can't be predicted because it depends on, again, where the destruction occurs. There are 4 types. The most common type is the relapsing remitting MS. About 85% are diagnosed with this type, and it's marked by a series of relapses and remissions that can last days or several months. The patient will report a loss of function and often new symptoms. During remission, the symptoms either fully or partially disappear. And shown here are some of the symptoms on this slide. The other types are primary progressive MS, secondary progressive MS, and progressive relapsing MS. A neurologic exam is used to evaluate and diagnose this condition. We may see also MRIs and other tests and cerebral spinal fluid, EEGs, blood tests, and disease biomarkers used to diagnose this. Common symptoms associated with MS include sensory loss, vision problems, muscle and motor impairments. Disease management usually falls into one of 3 categories: treating the relapses, treating the acute relapses, treatment aimed at disease management, and treatment of the symptoms. The most common treatment of acute exacerbations is corticosteroids, which reduce inflammation that spikes during a relapse. So we may administer IV salmeterol or oral prednisone. These medicines don't affect the outcome or degree of residual impairment, but they do treat the inflammation. We have to also be concerned if we're administering these medicines about the adverse reactions such as increased blood pressure, weight gain, and mood swings, and long-term problems associated with steroids such as cataracts, risk for infection, and high blood glucose. Actions aimed at disease management include disease-modifying treatments. And this may include decreasing the frequency, therapy aimed at decreasing the frequency and severity of the attacks, and decreasing the accumulation of lesions found in the brain and spinal cord, and slowing the onset of disabilities. So some medications aimed at decreasing disease-modifying treatments these medications are classified as interferons. These are proteins normally found in cells in the immune system in response to viral infections. So each of these medicines have similar actions, but they're interferons. They're administered subcutaneously every other day, and some of them are actually administered IM. There's a variety of different types of interferons, and I'm not going to test you on that, but I just wanted you to be aware that those are some of the classes of drugs that are given for this this condition. There's been a lot of evidence that suggests that regular exercise improves quality of life for these folks. It also helps to ease their symptoms. These folks tend to have problems with elimination. Constipation is a common problem because of the decreased mobility. So monitoring dietary intake, increasing fiber are important, giving stool softeners. They may also have bladder problems, and this is associated with interruption in electrical impulses to the muscles that are involved with emptying the bladder. So we may see some associated bladder control problems and bladder infections and kidney problems too. Personal hygiene may also be a problem, and social isolation of these folks. These folks tend to be very fatigued, so dealing with the fatigue and treating the underlying cause. Unfortunately, the exact cause of fatigue is often unknown. Some tips to help avoid fatigue for these folks is body mechanics. Teach the patient to practice proper body mechanics and limit work that requires reaching over their head or increasing muscle tension. They need to evaluate their energy levels, instruct them to pace themselves, advise them to alert to warning signs of fatigue. Attentiveness to personal situation. Teach them to know their own limits. Teach them weekly planning. Advise the patients to organize their week and plan for rest periods. Activities need to be prioritized, and rest is essential. Teach them frequent short rest periods are good, and exercise. And so you've got that acronym BEAWARE, BEWARE. Body mechanics, evaluation, attentiveness, weekly planning, activities, rest, and exercise. So there's your little memory jogger. Mood is also a problem with these folks, so patients with MS and their families must make many emotional adjustments to the disease and the change in lifestyles. Depression is really, really common. So support groups and getting in with the Multiple Sclerosis Society chapter may be helpful with this condition. The next condition we're going to look at is myasthenia gravis. It's a chronic and progressive autoimmune disorder which affects the myoneural junction, and that's the point at which a motor nerve meets a muscle fiber. It's characterized by weakness and easy fatigability of the voluntary muscles that worsens during exercise and improves in rest. The course of the disease is highly variable, and we have spontaneous remissions in some cases. Risk factors include infection, surgery, and certain human leukocyte antigen types. We see increase the risk for the development of myasthenia gravis. 5% of people have a family history of the disorder, And certain medications are known to provoke exacerbations in myasthenia gravis, including aminoglycosides, quinolone antibiotics, and class 1 antiarrhythmics. The signs and symptoms include generalized limb and muscle weakness, neck pain, head bobbing. So those are some common symptoms we see. So weakness, neck pain, and head bobbing. Ocular signs and symptoms include unilateral and bilateral ptosis, or drooping of the eyelids, and constant or transient diplopia, which is double vision. Facial signs and symptoms include inability to smile, an appearance of a blank, expressionless face, or snarl. Oropharyngeal signs and symptoms include hoarseness, drooping jaw, slurred speech, and difficulty breathing, chewing, swallowing, and uttering any type of sound. So this condition usually peaks in women between 30 and 40 years old, but men have it, and it's much more severe for them around the age of 50. Diagnosis is based on a tensilon test in which injections of acetylcholinesterase inhibitors are given and may show immediate improvements in muscle strength, and that's a strong indication that the condition is myasthenia gravis. We also see electromyography studies, including single fiber EMGs, to test muscle strength and repetitive nerve stimulation with electrodes. We're concerned with myasthenia gravis having a crisis, a myasthenia crisis. And if they have that, then they're at risk they're going to develop respiratory failure. Closely monitor for signs and symptoms of tachycardia, bradycardia, and signs of respiratory distress. Hydration status, electrolytes, and arterial blood gases are also important to be monitored, and pulmonary function test and signs and symptoms of infection. For someone that's possibly having a crisis, we may see IVIG and plasmapheresis ordered while waiting on corticosteroids to take effect. So, and that would be prior to having a thymectomy. So, with this condition, we see problems with the thymus, and a thymectomy is usually the treatment for this. So a myasthenia crisis is a crisis in which you see acute muscular weakness causing respiratory distress and requiring mechanical ventilation. So that's when it's really gotten to a critical point. Treatment as well for this condition includes nutrition education and pharmacologic treatment, cholinesterase inhibitors such as neostigmine or pyridostigmine are first-line medications for treatment. They help to slightly improve symptoms. Corticosteroids help improve weakness, but sometimes they need to be taken for up to 3 months before they reach their full effect. Immunosuppressants used alone or in combination with corticosteroids and cholinesterase inhibitors are also prescribed. So the pre-surgery and post-surgery for the thymectomy are basically like any other surgery. Pre-surgery, though, may include prescribing, giving cholinesterase inhibitors, down titrating the corticosteroids, and plasmapheresis. Post-care includes pain management, increased titration of the cholinesterase inhibitors, monitoring for respiratory distress, monitoring also for cholinergic crisis, and this is an overstimulation due to excess acetylcholine from too rapid up titration. Symptoms of a cholinergic crisis include excessive lacrimation and salivation, tachycardia, and diarrhea. So be able to differentiate between a cholinergic crisis and a myasthenia gravis crisis. Unfortunately, sometimes we see a mixed crisis as well. But so there's a picture of the cholinergic crisis to kind of help you learn that. A mixed crisis can include apprehension, restlessness, dyspnea, dysphagia, dysarthria, tearing, diaphoresis, and weakness. This concludes this first recording for Module G. Thank you very much.